Today my topic is unraveling disc edema. So we are just going to look at an overview of what all conditions we should think about when we see disc edema and how do we go about investigating. Because each one of these conditions is covered in detail later on, so I have not gone into detail about any of them. But always remember that disc edema is a sign, it is not a diagnosis. You know that it is swelling of the optic nerve head due to obstruction of axoplasmic flow. And when you have it because of raised intracranial pressure, then we call it papilledema. And in papilledema, the primary event is axoplasmic flow stasis that causes intracellular fluid accumulation. And underlying mechanisms of the disc edema vary depending on what is the condition that is causing the disc edema. So when you look at classification of disc edema by pathophysiology, we already said raised ICP papilledema. Ischemic can be arteritic AION or non-arteritic. Inflammatory or demyelinating will come in the optic neuritis and in the infectious optic neuropathy. Venous or vascular congestive disc edema you will get in CRVO, in papillophlebitis or the non-ischemic CRVO, and in a hypertensive and diabetic papillopathy. Compressive in optic nerve sheath meningiomas, gliomas. In sarcoid lymphoma also you can get compressive or infiltrative type. And the toxic metabolic in ethambutol, methanol, INH toxicity. Hypotony can cause hypotonic disc edema. Traumatic optic neuropathy can sometimes cause disc edema prior to the pallor, and hereditary or mitochondrial causes in Lebers you can have hyperemia and telangiectasia of the optic nerve head. Clinical classification is according to the course of the disease. Is it acute, is it subacute, or is it chronic? You know that the ischemic events are almost always acute, inflammatory are also mostly acute, and sometimes malignant hypertension and papilledema are also acute, rapid rise in the disc edema. The subacute causes are the compressive ones, the infiltrative ones, and the chronic ones are the chronic infiltrative conditions and long-standing papilledema. But for us, clinically, the easiest way to decide what kind of papilledema is, what kind of disc edema it is to look at whether it is one eye that is involved or both eyes that are involved, because the causes are different. When you're looking at a unilateral disc edema, then you're looking at conditions like optic neuritis, ischemic optic neuropathy, CRVOs, and compressive optic neuropathies, diabetic papillopathy, neuroretinitis, hypotony if it is post-op or traumatic, and the traumatic optic neuropathy. However, if you are looking at bilateral, then you must think about papilledema first, malignant hypertension, the bilateral infiltrative conditions, severe systemic illness, bilateral optic neuritis mostly in children, and bilateral diabetic papillopathy, which is also rare. Now, what to ask in the history? So, one we already said, onset. You want to know whether it has been sudden or the symptoms have come in over the days to weeks, or is it gradually over many weeks to months. Next, you should know whether the patient has pain, especially pain on eye movements. Patient may not complain of pain, but if you ask them whether there's pain on eye movements, they will give you that piece of clue that it is optic neuritis you're dealing with. Color vision, whether they have any symptoms related to color vision, and always remember it is not a gross color vision loss that you will get. You will only get as a mild red washout. So that has to be specifically asked. Then any recent history of surgery or trauma can be asked. Systemic symptoms of raised ICP, headache, vomiting, jaw claudication or scalp tenderness, history of hypertension, diabetes, absolutely important, whether they have been on any long-term medications, and any infection exposure. Once you have examined, you can use this part of the history retrospectively also. So in your examination, you're going to look at the laterality first. You're looking at visual acuity and color vision. You're looking at presence of RAPD. In the optic nerve appearance, what should you look for? You should look for, is it a pallid disc edema or is it a hyperemic disc edema? Are the disc margins smooth or are they lumpy? And how much elevation is there? Vessel obscuration. Are the vessels on the disc clear or the vessels on the disc are completely obscured? The amount of swelling. You should always remember that except in early papillodemas, it is only papilledema that can produce a huge amount of optic nerve swelling. The early papillodemas and optic neuritis almost always cause only very little optic nerve swelling. Hyperemia will be more evident, but the actual swelling will not be much. Peripapillary changes, are there those patterns, folds? Is there any atrophy in the peripapillary area? Are you looking at something like a myopic disc that is fooling you into being disc edema, and because it is tilted? Then you also have to look at the rest of the retina. Don't just look at the disc, look at the rest of the retina, especially in the posterior pole. All the hemorrhages, cotton wool spots, are there a lot of hemorrhages all the way up to the periphery, telling you that it is a CRVO, and whether there is a macular star. Now in this case, this is a 30-year-old female with intermittent fever for 2 weeks, developed headache, neck pain, photophobia and phonophobia. Even without looking at the disc, we will come to a clinical feeling that this patient is probably having papilledema because all the symptoms fit in with papilledema. Unilateral causes, optic neuritis. Typically, it's a young adult, often female, and often subacute. I think we have a full talk on optic neuritis, so I will not go into the details, but always remember that unlike papilledema, in optic neuritis, RAPD is a very clearly visible sign. Ischemic optic neuropathy, again it will be sudden onset, painless. If it is the arteritic type, it will be very older age group, and if it is a non-arteritic type, usually around 50 to 70 years. And you know that the ESR will be very highly elevated in arteritic, and in arteritic the disc will be extremely pale. But in non-arteritic, usually more of a sectoral edema with along with the signs of your altitudinal field defect. The actual decrease in vision can vary. It can be very mild, like 6.9, 6.6 parts, to really severe 660. And in the arteritic type, it can even be perception of light or counting fingers. CRVO, please remember that disc edema is only an incidental sign. But sometimes in the non-ischemic type, what was called papillophlebitis earlier, CRVO can have a misleading thing because the hemorrhages are not much. Let me go quickly into a small flow chart that has been made. Pseudopapilledema also, I believe there is another session. So let's go to this flow chart. So you have disc edema. Find out whether it is true or pseudo. Is there a lumpy appearance? Is there high hypermetropia? Then if it is true, you go into unilateral or bilateral. Unilateral, is it sudden onset or does it look like a chronic one? If it is sudden onset, there is pain present or pain not present? Pain not present, you may be looking at ischemic optic neuropathy. Pain present, optic neuritis. Is the posterior pole showing other findings? Hemorrhages in CRVO, choroidal folds in hypotony, macular star in neuroretinitis. If it is chronic, is there any EOM restriction or proptosis? Is the other disc pale? Are you looking at a Foster Kennedy? When it is bilateral, whether there is raised ICP or not raised ICP, and then you can figure out the rest using this flow chart. So with that, I come to the end of my overview of disc edema, and I also take this opportunity to invite all of you to Ignite, a dedicated uveitis CME, in January 10th and 11th.
Thank you. Thank you, Dr. Natasha. Thank you, Dr. Natasha. It was an excellent presentation. Only one more point I would like to add is the central fields. So in optic neuritis, central or centrocecal scotoma will be there. In AON, altitudinal type of field effect will be there. And in papilledema, enlargement of the blind spot initially. Later on, going in for peripheral constriction and total loss of vision. So all these have to be considered. And if residents are here, 5 points to remember while asking the history, what Dr. Natasha had told already. Duration, first is laterality, next is duration, third one is onset, fourth is pain, and fifth is progression. If you ask these 5 points, you can arrive at a diagnosis 90% of the times. Thank you.
Thank you. Thank you, Rena, for